Today's topic is abnormal uterine action. Abnormal uterine action is one of the factors causing dystocia, that is difficult labor, in which uterine forces are insufficiently strong or inappropriate coordinated to efface and dilate the cervix. Pelvic contraction is often accompanied by uterine dysfunction, and two together constitute the most common cause of dystocia. Similarly, malpresentation or large fetus size, that is macrosomia, may be accompanied by uterine dysfunction. As a generalization, uterine dysfunction is common whenever there is disproportion between the presenting part of the fetus and the mother. Physiology of uterine contraction is support to normal labor. Uterus bulk can be validated usually using the Montevideo unit. Montevideo units are calculated by subtracting the baseline uterine pressure from the peak of uterine contraction pressure for each contraction in 10 minutes window and adding the pressure generated by each contraction. Physiological control of myometrial activity takes place through the estrogen, progesterone, oxytocin, prostaglandin, cyclic AMP, calcium beta 2 blocker, amongst others. By the end of pregnancy, the balance of these factors is tipped, favoring an increase in uterine activity initiation labor. Their uterus, like other smooth muscles, exhibit waves of contraction beginning at the fundus downward to the lower segment. Contractions of uterus are parallel with cervical dilatation. The increased frequency and intensity of uterine contraction will cause descent of presenting part with progressive cervical dilatation and effacement. Assessment of uterine activity should include frequency, amplitude. Classification of abnormalities of uterine actions. Uterine overactivity, like precipitate labor, in which the absence of any obstruction is there, obstructed labor in presence of obstruction. Uterine underactivity, like also called uterine inertia, this may be due to hypotonia inertia 1, hypertonia inertia 2. Uterus is hyperactive with increase in the basal tone with no or minimal effect on dilatation and effacement of the cervix. This may include following types. A. Incoordinate uterine contraction, colicky uterus due to lack of synchrony of contraction of myometrium. B. Hyperactive lower segment due to lack of fundal dominance, contraction ring, constriction ring caused by localized annular spasm of the uterine muscle, cervical dystocia. Uterine hyperactivity, that is also referred to as the precipitate labor. It is a labor during less than 4 hours due to strong coordinated uterine contraction in the absence of obstruction in the birth canal and resistance of the soft tissue with a small size fetus. The patient does not feel except the last contraction during the expulsion of the fetus. Diagnosis. It is a retrospective diagnosis as patient is usually seen in the second or third stage of labor. If seen during the first stage of labor, the partogram will show the rapid progress of cervical dilatation and effacement. It's seen after delivery. Examination of the mother and infant should be performed for the following complications: maternal like laceration or any tear in the cervix, vagina, perineum, leading to postpartum hemorrhage. Atony due to uterine exhaustion may lead to postpartum hemorrhage. Shock due to hemorrhage or any pain. Fetus, intracranial hemorrhage due to rapid compression and decompression of fetal head during delivery. Fetal injury, avulsion of the cord, neonatal sepsis. Management, prophylaxis. A patient with the past history of precipitate labor should be admitted to hospital at the first perception of labor pains. Rarely, patients seen during delivery general anesthesia while nitrous oxide, oxygen, or sedation may be given to slow down the course of delivery or to prevent forcible bearing down. If the patient is seen after the exploration of the birth canal for any injury and managed accordingly. Prophylactic antibiotic if delivery occurred in unstable conditions. Proper examination of fetus for the detection of any complication to be done. Excessive uterine contraction and retraction in presence of obstruction, also refer uterine overactivity. In obstructed labor, there is excessive uterine contraction. In a trial to overcome the obstruction, there will be marked retraction and thickening of upper segment, while the more passive lower segment markedly stretched, thinned out to accommodate more and more of the fetus. Therefore, the retraction ring rises up and seen felt abdominally as a transverse groove that may rise to or above the level of umbilicus. This retraction ring, also known as pathological ring or Bandel's ring. Unless the obstruction is properly treated, the thinned out lower segment will rupture. Uterine underactivity. Hypotonia inertia 1. Definition: weak, infrequent, and ineffective uterine contraction. Etiology: not known, but following factor may be involved. General factor like primary gravida, especially elderly, anemia, chronic illness, hypertensive state with the pregnancy, nervousness, anxious patient, improper use of analgesia. Local 2. Overdistension of uterus by twin or liker, anomaly in the development of uterus like unicornate, bicornate, and subtate uterus, malpresentation and malposition, full bladder or rectum, uterine fibroid, induction of premature labor. Classification: primary inertia, where the poor uterine contraction from the start of the labor. Secondary inertia, uterine contraction begin to start with good uterine contraction, but later on, as they passes, they become weaker and weaker. Clinical feature: labor is prolonged at various stages of labor, detected clinically by partogram, prolonged latent phase, protraction disorder, and arrest of cervical dilatation. Uterine contractions are weak, infrequent, and have a short duration. This can be detected clinically by examination. On feeling the contraction abdominally, there is weak increase in uterine tone, uterine contraction in 10 minutes or less than 3 contraction, each lasting less than 30 seconds. Monitoring using external tocodynamometer by external sensors over the abdomen. Mother and the fetus are usually not seriously affected, especially when the membranes remain intact apart from prolonged labor. Complication: mostly that of prolonged labor, maternal in the first stage, nervousness, anxiety, exhaustion, and starvation, ketoacidosis. In the second stage, prolonged second stage, increased liability for instrumental delivery and cesarean section. In the third stage, retention of placenta and postpartum hemorrhage. Sub-involution of the uterus, risk of abuse of uterine stimulation. B. Fetal. Usually the no effect part from the fetal infection from the prolonged premature rupture of membrane. Treatment of hypotonia inertia. General measures: proper diagnosis that the patient is active labor and not in the prodroma of labor by the proper identification of true labor pains, rhythmic increase in the strength, frequency, and duration, and accompanied by bulge of the bag of the pore water and cervical dilatation. Exclusion of cephalopelvic disproportion and malpresentation so as to be managed accordingly. Proper management on the first stage of labor. Oxytocin stimulation. Aim is to increase the strength, frequency, and duration of uterine contraction. Precaution before and during use of oxytocin. There must be no contraindication oxytocin like CPD, scar, grand multiplier, fetal distress, multiple pregnancy. Close observation should be made. Continuous automated computer infusion pump is to be there for proper calculation of doses and delivery. Technique of IV oxytocin administration. Dissolve 5 units in 500 of lactate. So solution to contain 1 ml contain 10 milli international of oxytocin. Assessment of efficiency of uterine contraction. First is by clinical, in which hand is applied over the abdomen to detect for the frequency, regularity, duration, and strength. External topography tocodynamometer is applied on the mother abdomen to record uterine contractions. Operative interference. Artificial rupture of membrane may be effective, especially in case of hydramnios. Operated delivery indicated if labor is prolonged beyond the 24 hours or if there is fetal distress at any one time. Secondary uterine hypotonia. This condition usually follows prolonged labor with good uterine contraction which failed to overcome obstruction to delivery, especially in the primary gravida. Careful examination need to be done to detect the cause of obstruction. Caesarean section is the solution. Hypertonia inertia. Hypertonia inertia. Etiology not known. Anxiety, repeated rough manipulation, use of oxytocin, disproportion, malpresentation, malposition. Clinical picture: labor is prolonged, detected by partogram. Uterine contraction are irregular, and between the contraction, uterus does not get relaxed. There is relax with the increase in basal tone. This can be detected by external tocodynamometer. Contraction are painful. The pain precedes, outlies the contraction, and there is marked low vacuum. There is low cervical dilatation and effacement, membrane rupture early. Treatment. General measures to exclude any disproportion, malposition, malpresentation, proper management of first stage of specific medically should give proper analgesia. Cesarean section is indicated in case of disproportion, fetal distress. Contraindication, contraction or constriction ring. Definition: it is persistent, localized annular spasm of the uterine muscles. It occurs at any stage of labor, first, second, or third. If it is occurs, it can occur any part of it, but usually at the junction of upper and lower segment. Etiology not known. Malpresent and malposition is associated. Rough or repeated intrauterine manipulations. Improper use of uterine stimulants. Diagnosis. Contraction ring is frequently preceded by colicky uterus and patient is usually primary gravida. Contraction ring is only diagnosed by the vaginal examination. Ring is not felt per abdominally as with the pathological or appendal ring. It is suspected if there is prolonged second stage without any obvious cause. In third stage may cause hourglass contraction, retention of placenta and source of PPH. Treatment: exclude the disproportion, malpresentation, malposition, give proper analgesia. In the second stage, deep GA should be given and immediately baby should be delivered by the forceps phase. The ring is there, and cesarean section is needed where in the GA ring is cut. In the third stage, give deep anesthesia, mild nitrate inhalation, and remove the placenta minimally. Cervical dystocia. Definition: this is difficulty in labor due to failure of cervical dilatation within a reasonable time in spite of presence of strong, regular uterine contraction, no abnormality in the uterine expulsive power. Types: organic rigidity, stenosis of the cervix by fibrosis, previous trauma, surgical or amputation, cauterization, organic obstruction of cervix by cervical fibroid, malignancy. Functional rigidity, it is non-dilatation of external os in the absence of any organic lesions. The process affects the external os only, so cervix may be well effaced and head is well applied to it. Clinically, external os is felt as a hard rim. Complication beside the complication of prolonged labor, obstructive labor is very rare. Annular detachment of cervix may be. Treatment: in case of stenosis of cervix by fibrosis, cesarean section. Safest method of delivery if cervix failed to dilate reasonable time. In case of organic obstruction, cesarean section is the method of delivery. In case of functional rigidity, giving time to cervix to dilate. Give proper analgesia, antispasmodic like Uteirne, Buscopan. If fetal distress occurs with the cervix less than half dilated, head is not engaged, cesarean section. Fetal distress occur with the cervix taken up more than half dilated, head is deeply engaged, cesarean section safe, preferable solution. Thank you.